everyone. Thanks so much for joining our session today. Is a learning exchange on supports for workers responding to overdoses in Ontario. Just to the next slide, please, Trudy. Great. So before we get into all of the speakers and our discussion for today, just starting with a couple of acknowledgements. First, our land acknowledgement. We're hosting this webinar from Toronto. It's the traditional territory of many First Nations, the Mississaugas of the Credit, the Anishinaabe, Chippewa, Haudenosaunee, and Wendat people. Home to many diverse First Nations, also covered by Treaty 13 with the Mississaugas of the Credit. We are working in our project on supporting and having our commitment on supporting meaningful relationships between local work on overdose response and Indigenous communities together. And we have our learning series together led by Indigenous groups for that work. Our other acknowledgement starting out is on the strengths, innovation, and leadership of people who use drugs and being so essential to this work and acknowledging the loss that many have experienced. For today, we do want to acknowledge the heaviness of this topic around overdose, the ongoing grief, loss, and trauma for people who may be on this call and in communities in the current context of multiple crises, and just to support everyone to take a moment for yourself if you need to step back and or to seek any support around anything that arises for you with this topic today. I'll pass it over to Tish for the opening from the Ontario Network of People Who Use Drugs, and the co-moderator for today.
Thanks, Pam. Good afternoon, everybody, and thank you for coming. Thank you for spending your energy here and coming together to present on this topic. My name is Letitia Mizon, and I'm here on behalf of the Ontario Network of People Who Use Drugs, which is a fairly new founded network led by drug user groups and initiatives and networks across Ontario. We're a provincially based association who aims to take the lead in advocacy by means of drug user-led initiatives in their own communities who are committed to representing and protecting the interests of diverse populations of the people that we actively serve. ONPUD's vision is an Ontario where people who use drugs can thrive. Our purpose is to unite and work together to encourage communication, increase capacity, advocacy, shape policy, laws, and modifications to services where we find that our voices are not actively at the table. Being the unpaid first responders with very little resources and access to supports, we believe in the importance of today's topic to increase capacity and awareness of supports. We would also like to remind you that the work done on the ground is never ending, and we see ourselves and our loved ones rapidly losing to the antiquated war on drugs, the war on the disabled, and the war on the poor. We ask that you be an ally and support our mission to properly address long-term policy changes, such as decriminalization and legalization of all substances, and ensure meaningful engagement with people who use drugs. We also urge those with the ability and access to power to join us in the fight for our lives, and hope that beyond this conversation, that each of you are examining your place and purpose in this fight and will reach out to align with our network should you see that as beneficial. Our ONPUD network can be reached by ONPUD, so onpudwg@gmail.com. And with that, I'll put that in the chat as well in case you want to reach out. And with that, I would like to invite you all to share a moment of silence for our loved ones gone too soon.
Thanks very much, Tish. So next we'll get into the 3 speakers for today. And so it's my pleasure to introduce our 3 speakers in order, Jillian Kola, Juno Zavitz, and Tridi Karache. Their organizations are listed here. We will also have a panel discussion with Randy Roberts, Jordan Lindsay, and Thomas Eichler, hearing from lots of different perspectives and great work today. The objectives of our discussion are really to talk about information about the needs of workers experiencing grief and loss due to drug poisoning, describing the current and future supports, challenges and opportunities to support workers, identify resources for supporting workers responding to overdose. So just before we get into those 3 great and short presentations, we just have a couple of polling questions, just so you can introduce yourself among each other, who's in the room, what area you're coming from in the province first. Okay, and Lydia, when you're ready, if you can just post the results. So there's lots of representation from around the province. So thanks for sharing that with us, and great to connect with you so widely across the province. And then the second poll here is about the type of organization that you're working with. You can choose multiple as well. And when you're ready, Lydia, if you can just display. So many from community agencies and public health, some from drug strategies, other drug user advocacy groups, and some others as well. So a great group for this discussion today. Thanks for participating in that poll, just to kind of have some sense of who's in the room with us. So next we'll be hearing from Jillian Kola, and excited to hear her presentation on the needs, gaps, and recommendations for supports for harm reduction workers in Toronto. So over to you, Jillian.
Thanks so much, Pam. And so my name is Jillian Kola. I'm from the University of Victoria, the Canadian Institute for Substance Use Research, but I also work here in Toronto. And I'm going to present to you some of the results from a study that we did here in Toronto with both communities of people who use drugs as well as frontline harm reduction workers. Next slide, Tridi. Perfect. And this is the Public Health Ontario disclaimer. Next slide, please. So just to get started, one of the reasons why we designed this study was because myself and the other investigators who undertook this work were working very closely with people who were on the front lines of the overdose crisis. We recognized that people who use drugs as well as harm reduction workers were the ones who were at the very forefront of designing and implementing overdose response strategies from the earliest days of the overdose crisis. And despite this work that was going on very, very actively on the front lines, there was very little research on the impacts about witnessing, experiencing, and responding to so many overdoses. And this also had translated into a lack of formal supports for people experiencing overdose, who were engaged in overdose response, and who were suffering overdose-related losses. And I think it's just very important to say right from the outset that the group of people who use drugs and harm reduction workers, they're not two separate and disparate groups. There's people who use drugs in all different groups of society. And so when I talk about the results from this study that are very specific to harm reduction workers here, this includes people who use drugs, some harm reduction workers who don't identify as people who use drugs. So this is a very disparate group of people who are working together to address the overdose crisis. But it's important not to try to make distinguishing lines between them. Next slide, please. So in our study, just very, very briefly, what we did is we did 249 surveys in early 2019 with participants from 4 different organizations that were running overdose prevention or supervised consumption sites at the time. We also conducted one-on-one interviews with 17 people who injected drugs and who had experienced and witnessed an overdose. So experienced an overdose themselves, as well as witnessed an overdose in their community, as well as with 11 current or former harm reduction workers. And so I'm going to tell you a little bit about the results that are very specific to this work that we did with the harm reduction workers and what they told us about their experiences. Next slide, please. And so this, I think that it got put into the chat. Most of the findings that I'm presenting today actually formed the background of a brief report that the MAP Center for Urban Health Solutions at St. Michael's Hospital put out. And I think that the link is in the chat if you want to go look at it. This is the first of 4 planned brief reports that we're going to be putting out. The next 3 will focus much more clearly or much more will focus much more on the experiences of people who inject drugs and their experiences of overdose. And so next slide. When we talk about the experiences of harm reduction workers, it probably won't be a shock to anybody in the room here that we're primarily talking to people about some very, very strong and difficult emotional reactions that they're having. The scale of the overdose crisis, the number of overdoses that people are responding to and witnessing, were leading to people expressing feelings of helplessness, of stress, and anger, mostly tied to the way in which these losses were preventable. And yet there didn't seem to be any kind of organized response that was happening to this crisis that was deeply affecting communities of people who use drugs. People also expressed a lot of guilt. And I think that this, if you look in some of the literature around grief and loss, feelings of guilt are very, very common. People, harm reduction workers were talking a lot about different forms of survivor's guilt, guilt around not having to be able to do more for their clients, as well as guilt at not being able to properly grieve the multiple and repeated losses. And this quote that you see on the screen there, where the harm reduction worker is saying that you feel guilty spending more time thinking about someone else and grieving that loss, paying more attention to that loss than you did another loss that was also significant, because right now in the last couple of years, there's just no time to give proper attention to death. And this was very, very commonly expressed by people where the scale and the number of losses that people were suffering meant that they were unable to fully grieve the people in their communities that had been lost. Some of the harm reduction workers we talked to also talked about changes in their social relationships and in their own patterns of drug use. They report being very overwhelmed by the continuous losses they were feeling. The last quote on the slide really speaks to that. They spoke about being hesitant to get close to people because they were worried about anticipatory loss, or they were worried about future losses that they might suffer. And some people reported that they were using drugs to cope with loss. Others reported using less drugs. Some reported different changing patterns of use as well. Next slide, please. The next set of findings are around how people's experiences of overdose were not confined to their work lives. We tend to have this division where we think about professional lives and personal lives as being neatly divided, but this wasn't the case with harm reduction workers. They really felt like there was a lot of intersections between their personal and their professional lives, how they felt more prepared and equipped to respond to overdoses that occurred at work, but that they also found themselves frequently being called upon to respond to overdoses in their personal lives as well. And again, the trauma from responding to multiple overdoses in multiple settings was very much compounded. And in terms of their experiences of grief, people really were not able to set boundaries between their personal and their professional lives and their grief. And this last quote really speaks to that, where the person says, it's not like you can just turn off caring. You're thinking about them when you're at home or whatever. And it's just like, oh, cool, I'm in bed and I'm like crying about someone from work. And so I think that this really talks to how the nature of overdose, the overdose crisis and overdose response is really permeating all aspects of people's lives. Next slide, please. One of the other things that harm reduction workers told us about very, very frequently was that they were having to, or they were being called upon to help support clients with their experiences of overdose-related loss. And they spoke about how because there was a total lack of resources for people who use drugs who required support for overdose-related grief and loss, harm reduction workers were being called upon to try to fill this gap and provide supports while also attending to their own personal emotional needs. And that this was very much compounded by structural issues that people who use drugs were facing, that their clients and the people they were working with were facing. And this included the lack of housing. Oh, good, the slide's up there now. This included some of the structural issues to do with lack of housing, the crisis of homelessness that we're facing in several cities throughout Ontario, and the way that this is intersecting with the overdose crisis was very much mentioned, and I think is very much worse now than it was 2 years ago when we did this study. But there was also very much issues of stigma and discrimination felt by clients that harm reduction workers were reporting trying to help them cope with. And in relation to overdose, this came very much from the fact that people were frequently in hospital emergency rooms following overdoses and would experience very large amounts of stigma and discrimination within healthcare settings following overdose. And that this actually compounded the difficulties for clients in coping with their own overdoses. And it was a major issue for harm reduction workers as they were trying to help support their clients. Here, somebody says, I think the hospitals are a big thing. When people go in on overdoses, a lot of times they're treated like third-rate citizens and they're treated like they don't matter. And so I think that we really also have to pay attention to the factors outside of the overdose response in terms of structural issues and the way in which stigma and discrimination are still impacting on people's experiences within the healthcare setting, healthcare system. Next slide, please. The next slide talks about workplace supports and gaps that are felt, that harm reduction workers were feeling. They said that their major source of support as they attempted to cope with overdose-related loss was other people involved in frontline overdose response. This was people who knew what they were going through, who were also going through the overdose crisis with them. And this was where they felt that their needs to be listened to were very much being met. However, and you can see this in the first quote on the slide here, sometimes people felt like because everybody was going through the same crisis and everybody was just barely staying above water, that they didn't want to burden others who were involved in overdose response with their feelings and their emotions. And you can see this when the person says, like, you're coping with stuff, you don't need to also hear about my stuff. A lot of harm reduction workers, in terms of the gaps that we identified in our research, they identified a hesitancy to open up to supervisors and people who were at the managerial level within their organizations. Some people were worried that if they started to talk about the emotional impacts that they were facing, there might be negative repercussions on their employment. And there was a real big gap around the lack of access to benefits and to counseling supports that was identified for people. And this was often tied to the fact that a lot of harm reduction workers are either on contract or in part-time contracts and therefore didn't have access to things like sick days, vacation days. They didn't have access to health insurance where they could get even a small amount of support to pay for counseling. And also it's very important to note that people really highlighted the complete inadequacy of employee assistance programs in addressing and helping them to support them around the overdose crisis. There was people who overtly talked about how talking to EAP, that they reached out for support from employee assistance programs, and that had actually been actively harmful in terms of the stigma and discrimination that they had faced from the employee assistance program counselors, and that it was very, very difficult. The short timeframes were also difficult and were also highlighted by people. So the next slide, we start to talk a little bit about recommendations from this study. And it's actually very encouraging to note that some of these recommendations actually have already been being put into place. And I'll get to that in a second. But one of the major recommendations was around the expansion of employee organizational employment policies to ensure that people had access to adequate pay, that people had access to benefit coverage, including sick days and vacation days, and that part-time and contract workers had access to counseling supports from their workplace, or that was somehow supported by their workplace. We highlighted the need for organizations to dedicate resources to individual and collective grief and and loss supports, as well as external supports for people so that they could very easily go outside their organizations to have access to external but qualified and easy to access counseling supports and support staff for them. And we also highlight the need for support for workforce development and professional development. There's some people who really feel like they can't continue to work within the overdose response because of the emotional impacts that this is having on them. And these are people who have a huge amount of expertise. And so we have a recommendation around how organizations should look into how to transition people into other forms of work within organizations that make use of people's expertise, but that gives them a break from frontline overdose response if the emotional impacts are feeling like it's too much. And we really talked about the need for some form of well-resourced counseling services to address the complex and multiple intersecting traumas that people are facing and have faced. And again, I'm very excited to hear Juno talk about some of the work that's been going on in Toronto around this already. Next slide, please. But I think the most important recommendation is around how while it's very, very important to provide supports for workers who are on the front line of the overdose crisis, we need to actually look at how we can stop the overdose crisis completely and how we can address the overdose crisis. Because the fact of the matter is we can't keep on helping people, putting Band-Aids on people. We actually need to stop the crisis of overdose deaths and the drug toxicity deaths at its source, because otherwise all of the grief and loss that we're facing is just going to continue. And so I think that it's very important as well to move beyond supports and think about the structural factors and the social determinants of health that are very much impacting the overdose crisis. And here, this means very centrally that we need to talk about the decriminalization of people who use drugs, because criminalization has only made the overdose crisis worse, and it's making it difficult to also address the overdose crisis. We need to talk about safer supply as well as drug market regulation to address the root cause of this, which is the toxicity and the volatility of the unregulated drug supply. And we also need to talk about the affordable housing crisis and the way in which intractable poverty, food insecurity, and a lack of affordable housing options is very much making the overdose crisis worse. And that we need to talk about all of these things together as we also address the needs for supports among harm reduction workers. And at the very end, my last slide, I just want to say a very big thank you and express my sincere gratitude to the people who participated in this study. I think one of the big almost red flags for me as we were doing interviews with harm reduction workers was they were actually thanking us as researchers for coming in and asking them questions about the grief and the loss they were suffering, because they felt very much like they had been abandoned to address this on their own. And I think that that just speaks so much to the need to really pay attention to this very, very important issue and to start putting in place the supports for people who are on the front lines of the overdose crisis. So thank you so much for having me here today. My email address is on the screen there, and please don't hesitate to get in touch with me if there's any further questions, as I realize this was a quick overview of our research today.
Thanks so much, Jillian. This is amazing work. Congratulations to you and your team, and for providing such a comprehensive kind of overview of the different levels that supports are needed. So next I'll introduce Juno Zavitz, presenting on Grief, Loss and Wellness Initiative developed by Breakaway Services. So we get to go a bit more in depth into one of the types of support. So welcome, Juno.
Thank you, Pamela. Hi, folks. Juno Zavitz, they, them, or he, him pronouns. This timing works out really well because Jillian's piece of research, that piece of research by a number of folks, was really instrumental in paving the way for the Grief, Loss and Wellness Initiative that we are building at Breakaway. I'll just locate myself quickly. I'm a settler of European descent living in Toronto. I have lived experience of drug use and professional experience, both within harm reduction and bereavement, as well as the lived experience of a significant suicide death. So I come to this work both with a background in lived experience and education in social work. So we'll jump right in. Next slide, please. And this again is the disclaimer from PHO. We can go to the next slide. Okay, so the link for the website has just been popped into the chat. I will say we are having a little bit of glitch issue with the website. So if it's not super navigatable, I understand we are working on it. There should be a version 2 coming out soon. So just a very quick overview, because I've only got 10 minutes or so. What I'm here to talk about today is the Grief Loss and Wellness Initiative, which is a new program that was founded in January of this year at Breakaway Community Services, which is a multifunction harm reduction mandated agency in Parkdale, Toronto, so west end of Toronto. Historically, higher rates of substance use, high population of newcomers, Indigenous folks, Black folks, marginalized folks, and that is where this work is being housed. This program is the result of a number of different people from the harm reduction community, both community members, service users, and workers, pushing to have some kind of worker wellness initiative launched. So we have been working on this for a number of years in a number of different pockets. And we're funded from a number of different streams right now. The biggest chunk of our funding does come from SUAP, which was granted to us of this year. We have 2 years of funding from SUAP. This pays for worker wellness, grief and death response for the harm reduction sector. We also have a small pile of money from the Ministry of Health administered through STRIDES, which we are doing some psychoeducation around youth and family support specific to the intersection of grief and loss and substance use support and youth mental health, as well as the City of Toronto, which has been funding the really lovely grief kits that we've been distributing to harm reduction workers and community members, as well as immediate support, which was originally via a warm line, which we are now pivoting to launch a rapid response team that will roll out in the coming months. And I'll talk a little bit about that at the end. But the mandate of the program is to provide direct service and capacity building supports to frontline workers and those who provide supports to people who use drugs within the context of the overdose crisis. The eligibility there is kept intentionally quite broad, that we knew we would miss the people who need this support most if we were only looking at supporting folks who are formally employed at CHCs and other harm reduction agencies. So from the outset, I want people to know that for people who are peers providing support to their friends, doing overdose response, people who are using drugs themselves, are not formally employed in the sector, do not have a background in social work, they are the people that we are most looking to serve in this work, and they are the people who we have built this program for. So really important to remember that that's who we're trying to capture here. I also like to distinguish this difference between direct service and capacity building supports, which I will talk a little bit about in the next slide when we did our very quick needs assessment last year. But there's a difference in the way we are trying to approach these things in actually wanting to offer those counseling services, grief and loss services, body-based services, et cetera, instead of just continually throwing capacity building supports like workshops and asking people to build resiliency. So that has not been the aim of the program. We will have an arm that does capacity building supports that will be disseminated nationally and internationally. That's year 2 of our SUAP funding. But we knew the most important thing in this first year was rolling out those direct service approaches. So mandate to address grief and loss worker wellness in the overdose crisis. And we've kept wellness in there very intentionally because we recognize that this is not just an issue of grief and loss. It is an issue of trauma, of burnout, of separation, of attachment trauma. It's so many things. This is not just a grief and loss program. The aim is to provide those wellness supports that agencies have not been providing to their staff or their community members. So we'll go to the next slide, please. So very quickly, the initial needs assessment we did in 2020, while I was furiously writing grant applications to try to get this work off the ground, we knew that the existing focus, where we were addressing anything to do with grief, loss, trauma, burnout for workers and community members who are peers, providing that peer support, was happening in the form of capacity building. It was trainings, it was workshops, there was a focus on self-care, there was a focus on building resiliency. I would be very happy if I never have to use the word resiliency again in my work, because people have been resilient, and now is the time for community care. So what we found in this needs assessment was similar to what Jillian had just said. There were no direct service supports. There were no counseling supports. Even if folks had benefits, if you were lucky enough to be a full-time employee with benefits, maybe even in a unionized position, you maybe have $200 to $400 a year for mental health coverage, right? And then, you know, if you're in a part-time position, you don't have benefits. And if you're not even formally employed, you're not being paid for this labor, you have access to basically nothing, right? One of the other findings we have so much anecdotal data that what Jillian had just said too, EAP is not the right fit. People will not even try EAP if we suggest it right now. We also found that management staff was not the right fit, potentially because of misunderstanding, but also because there was, and this relates to the second bullet point here, there was a lot of apprehension around accessing supports from one's own agency. So we knew that in order to provide the safest care possible, Breakaway was going to be a good fit because we are not a supervised consumption service. We are not an OPS. We have a little bit more distance from folks who are working at OPSs and CHCs. And those folks were telling us that they were not comfortable going to their own agency because there are already so many multiple relationships in this work to be asking for wellness support services and disclosing things that people rightly feel could jeopardize their employment was not going to work. We found a lot of best practice guidelines, research, and recommendations for how to better support workers in this field. But what we knew was these workshops, these trainings, again, to enhance resiliency, crisis response, self-care, and professional skills were going to be useless because we can't build capacity on top of people who are already burnt out, right? So we'll go to the next slide. So what we have done is put together a program that offers that direct service. And we say it is wellness-based we know it will always have strong themes around grief and loss, trauma, and burnout, but at its core, it is wellness services for workers. So the bread and butter of what this program looks like right now is free individual support services that folks are able to access through 11 different practitioners that we currently have on the roster. This pool is expanding every month, and I am always open to suggestion about who to include if there's a gap. The modalities on offer that, again, those frontline workers and community peer supporters can access are a massive, massive range. And this is something that's been really meaningful to have great feedback around, is that we have really covered our bases with the things on offer. So we do have traditional psychotherapy, counseling, peer support, grief and loss support. We have arts-based healing practices, Indigenous specific support, which includes herbal medicine, songs, drumming. We have 2 acupuncturists, one who does nada, one who does general acupuncture, cupping, traditional Chinese medicine, massage therapy, somatics therapy, and spiritual counseling and use of ritual. So we have kept this really intentionally quite broad because we know there's going to be many, many different needs in the wellness that's on offer. In terms of longevity of the support, I did not want to set a time limit on how many sessions folks could access, but we are now in the position of having to set very gentle, fluid limits in order to get as many people into this program as possible. So what it currently looks like is people make first contact at Breakaway, which is either through me or my coworker Kai, who is the intake coordinator. They do a very gentle, narrative-led info gathering session with Kai to figure out how we can best support them. Kai connects them with the practitioner or practitioners of their choosing, and they are welcome to do 6 to 8 sessions, after which they'll do a check-in with Kai, and if there's a need for future sessions, we provide future sessions. Because one of the things we are hearing is that when folks get to the end of those 6 or 8 sessions, they are maybe at the point where they are just starting to find some stability and just open up, and to pull the rug out from under them would just not work, right? We also know that this is not a one-time issue. The trauma and the burnout of the grief and loss crisis, even if we were to end this crisis tomorrow, is here to stay, and is here to stay for many generations to come, right? We can think about like the 7th generation model. We know this is going to take more than 6 to 8 sessions. So we're trying to find a way to include as many people as we can, and also make sure we are providing as much support, longevity as possible. So future modalities, we will be adding additional Indigenous specific supports and spiritual wellness. We are looking at also adding some kind of palliative support care or death doula kind of support, especially for older adults who are potentially experiencing the grief and loss with a terminal illness diagnosis they've just received, and are also people who use substances. We know that hospice and palliative care has not done a great job at supporting people who use drugs. We want that to be part of the program as well. And then 2 pieces that I'm really excited about. One that we know will happen for sure, that we have received funding for, is this rapid response team, which will be a team housed at Breakaway that can be mobilized within 24 to 48 hours when there has been an overdose within the city of Toronto or GTA, and a team needs that grief, loss, stabilization, debrief support. We will be able to send people out. And the other model we're looking at, that was a suggestion from a nurse practitioner at an OPS in Toronto that I absolutely love, is what I'm calling a bursary model, which means that essentially Breakaway will foot the bill for whatever practitioner you want to see out in community at the same rate that we pay our in-house practitioners. So you bring us the bill for whatever wellness modality you've chosen, and we will cover up to $100 of that session for you. And we're already hearing some really creative feedback about what could be included in that. Someone had named ayahuasca ceremonies as something that would be hugely, hugely impactful for their wellness, potentially psychedelic assisted therapy. Like, the possibilities are endless. So this bursary model and the rapid response team have not been launched yet. The bursary model is something that is we really hope to make available, but the rapid response team will be launched by the end of this calendar year. So we'll go to the next slide, please, and I'll wrap up because I know my time is coming to an end. So preliminary recommendations, Jillian has covered a lot of these. These are pretty straightforward, and people have been screaming them into the wind for years. 1, offer supports during working hours. We are waiting on additional funding from SUOP so that we can assist agencies in back paying relief, so that those workers can step off of the work floor and access these supports during their work time, because it is work related, it is professional development. If they elect to, it will not be mandatory, but this will catch those people who are not interested or do not have the capacity to access these things on their off time. Focus on direct service before capacity building. I know there are so many beautiful capacity building models and workshops and trainings and skills out there. Our sense was that we need to be doing both, and we hope that this model that we are using at Breakaway is scalable and replicable out in communities outside Toronto, because that is the eligibility for now. Unfortunately, it is just people in the city of Toronto. So that goes with including this menu model that we've gotten a lot of great feedback about, as well as this understanding that wellness support, and this should also say basic human needs, are grief support. So those things like housing, food security, access to a safe drug supply, reliable income, and basic wellness supports in whatever way a person defines wellness support is grief support. So we often want to get really highbrow with our interventions around grief and loss, but at the end of the day, needing to remember that we have some very basic needs that we have not yet met for folks. Group and individual support. We have put group support on pause for the time being, but that was on offer for the majority of this year and likely will resume over the winter. Broad eligibility, so making sure we are capturing those folks who are the first responders, will always be the first responders, who are people who use drugs, that they are eligible just the same way frontline workers are. And wellness-oriented spaces, and this is what I call a backdoor approach to grief and loss, which means that in order to witness and to see and to validate grief, we don't always need to be throwing people into a grief focus group, right? We know that sometimes it's just really meaningful to bring folks together for a community meal where there is a tacit understanding that everyone in this space gets it and knows what it's about, but maybe we just need a moment for respite and to eat together. So those are some of the things that Breakaway is planning over the winter, and that we were also able to do in the summer on August 4th with the support of community partners to launch an inaugural Worker Wellness Day. So go to the next slide. Hopefully that's the end of my slides. Yeah. And I'll wrap up by saying, so next steps that I've talked about, rapid response team is coming to do this crisis response debrief, immediate grief and loss support. We will be doing capacity building and training for staff and community members to support skill development. But I know Thomas Egdorf is here from the ABRPO, and they have a wealth of information that already exists. So not wanting to reinvent the wheel with that stuff. Bursary model we hope to launch. We are also working on policy development, and we have some irons in the fire around policy advocacy happening with AMHO that we're working on right now, as well as some advocacy to funders at the provincial level. And happy to report that some of the advocacy work that we have done has resulted in changing some of the tough Toronto urban health guidelines around what can be funded. So it is happening very slowly, but it is happening. So if you would like to get in touch to access this program, to replicate, to pick my brain, to Skillshare, to collaborate, please do get in touch with us. We are just halfway through the first year launching this program, much to learn still, and really excited to see what else folks are talking to today. And again, Jillian, thank you for your work around this. It really paved the way for being able to push this out into community. So thank you.
Thanks so much, Juno. I was seeing some of the comments come in the chat and lots of words like wow and fantastic, and really thanking you for your work and for sharing with us today, and just also demonstrating such a commitment to all of that collaboration that you bring and care to workers. So our final presentation is Tridi Crochet speaking on the findings from a rapid review of the literature and support on the supports for workers responding to overdose. So this is seeking out broadly what's the evidence and what are some of the gray literature resources that we could find around this topic. So I'll turn it over to you, Tridi. Thank you.
Thanks so much, Pam, and thanks so much, Jillian and Juno, for your important presentations and the work that is being done. As Pam mentioned, my name is Tridi Crochet, and I'm a research coordinator at Public Health Ontario, specifically working on the Community Opioid and Overdose Capacity Building Project, or COMCAP for short. Just before we go to the panel presentation, I'll be presenting on some preliminary results that we found from a rapid review on organizational supports for workers responding to overdose. I know there's a bit of a lag with my slides, so I'll try to pause and wait for it to come up. Okay, so a bit of background just quickly on this work, and the need for understanding the current literature on organizational supports really emerged through our work with our community partners on the COMCAP project, who are seeking ways to best support workers with increasing stress and grief and trauma and burnout from overdose response, and just the total community loss that's been experienced and heightened in the context of COVID-19. So we conducted a rapid review to better understand what organizational supports were described in the published and gray literature. And we defined workers as those who are formally or not formally employed for overdose response work, similar to what Juno described, as recognizing that community members who are really at the forefront of responding are not always formally employed for all their overdose response work. We looked at supports that were offered by organizations versus those that looked at individual habits or self-care activities, and specifically looked at organizations in the substance use and mental health and substance use sector, harm reduction, HIV/AIDS, and healthcare sector, although recognizing that the drug poisoning crisis kind of spans across multiple different sectors. We used two frameworks to support our understanding and analysis of the literature. First was this conceptual model proposed by the Center for Work, Health, and Wellbeing at Harvard that shows 4 different levels and pathways that affect workers' safety, health, and wellbeing, including the broader social, political, and economic environment, which in turn influences the employment and labor patterns that impacts organizations and workers' behaviors and health outcomes. And we supplemented that framework with one called the Total Worker Health Approach that's proposed by the National Institute for Occupational Safety and Health from the CDC, which similarly recognizes that integrated strategies that address workplace practices are critical for addressing the multiple factors that influence workers' well-being. Some of the kind of categories here are built environment supports and technology and work arrangements, just showing the different breadth of supports that are needed. And we'll touch a bit further on this as it applies to the literature on overdose response. In terms of our approach and to find relevant literature, we searched both electronic databases and Google for both published and gray literature records. We included and screened records that specifically targeted grief, trauma, stress, or burnout as a primary focus, and focused on the sectors that I previously mentioned. We included any study design, so newsletters, commentaries, or editorials that included sufficient details and information on specific programs and examples of supports that were either implemented or recommended. And we looked across the different records and grouped common supports based on the categories of the total worker health approach that I presented on the previous slide. In terms of what we found in our search, there was only 10 records that met our criteria. Most of the records were from Canada or the United States and in the context of the drug poisoning crisis, but there were others from South Africa and Australia as well. The types of records that were included were qualitative articles, reports, guidance documents, and one review from the gray literature. And there was a range of workers in which supports were described for, ranging from harm reduction workers, healthcare professionals, and workers in HIV/AIDS services. So in the next couple of slides, I'm just going to be talking about the most common support categories based on the total worker health approach and the supports that were identified in each. So the most common identified category was compensation and benefits, and specifically around facilitating access and referrals to support services and resources. So this was described as either providing internal services or referral pathways to external support services and resources, such as counseling. There was little information on how access was actually facilitated, and when it was described, it was either organizations coming together to work together to provide supports, or one record actually described creating a specific role to help navigate access to external support services. As Juno had mentioned, there was quite a few articles that talked about training and skill development opportunities with respect to topics that were often covered related to grief and loss, compassion fatigue, mental health symptoms, and coping strategies. And the less often described in the literature were around health benefits, paid time off, employee assistance programs, and adequate wages for workers. The next common category was organization of work, specifically enabling mutual support and providing opportunities to debrief. With mutual support, several records talked about the important connection and support that they received from coworkers, but the insufficient resources to enable mutual support and not wanting to further burden coworkers experiencing their own grief, as Jillian had mentioned. The support that was described was really ranged from more informal one-on-one supports to more structured mentorship and mutual networks and support groups, and providing opportunities to debrief with the purpose of providing and creating a space for workers to come together to discuss and share and learn how to deal with experiences of grief and work-related stress. And this was described both at the group level and individual debriefs, recognizing that both options need to be offered to meet workers' preferences. but the design and delivery of these debriefs really varied, whether they took place immediately following a loss, who led the debriefs, the length and the frequency of them as well. Healthy leadership was another common category, and within this, the focus was largely on strengthening management support. So many documents that describe the worker's perspective talked about how the unhelpful characteristics of management and the need to improve management being more knowledgeable and experienced and empathetic, and having an open door policy, regular check-ins, and connecting staff to supports. Clinical supervision was also described in about half of the records, with the need to have someone who's not responsible for performance reviews and who had appropriate knowledge and training to provide debriefs, counseling, and grief support. I won't go too much in detail in this slide, but these are just wanted to highlight the less common support categories that were identified around organizational policies around grief and loss, whether those were standalone policies or integrated within broader wellness plans of organizations, community supports, so centralized supports, and collaboration and coordination with other organizations. And one article from Australia focusing on Indigenous workers in the substance use sector described the need to build the cultural competence and cultural safety of staff that were non-Indigenous, and overall increasing the number of Indigenous workers in the substance use sector to reduce stress among those already employed. So we're still in the process of reviewing and discussing our preliminary results with our collaborators, but I wanted to just share some initial gaps that we've noted from the small amount of literature that met our eligibility criteria. First was the need to address inequities in supports, particularly as it relates to the equitable access to supports across diverse workers, particularly those who are not formally employed in their overdose response work, and also being able to provide supports that are culturally safe and appropriate to diverse workers. Another gap that Jillian and Juno touched on is that many of the supports that were identified in the literature were said to be either poorly executed, they were not always helpful, or some of them were even harmful, such as employee assistance programs. And this further demonstrates the need for ongoing collaboration with workers to understand what does and does not work to address their needs. As well, for our rapid review, we looked across a range of different types of workers, and understanding the factors that influence the effectiveness of different support strategies for different workers and settings and contexts is really needed, and to also understand unintended consequences that some of these supports and services might be having and contributing to increasing stress and burnout among workers. Lastly, as both Jillian and Juno had mentioned, we found most of the supports focus really on the individual level knowledge and skills, or individuals accessing supports, while addressing organizational and community level factors were less common. As highlighted by the two frameworks in Jillian and Juno's presentations, the health and well-being of workers is influenced by multiple factors, and it's important to consider these in the design of more sustainable support options. So I'll leave it there. Please feel free to reach out if you have any specific questions. We will be working to finalize the rapid review and posting it to the Public Health Ontario website in the upcoming weeks. And I'm looking forward to the panel discussion. Thank you.
Thanks so much, Trudy. Thanks for all of your hard work to bring that information together. And I think there's a lot of connections with the other material from the other two presenters, and certainly seeing that, you know, the state of where the information and practice is at right now leaves a lot of work to do, and only finding about 10 records that really address this so far in the literature, and lots of gaps that we've noted so far. So we look forward to finalizing that work to be able to share what is out there. And now we're on to our panel, and we have lots of time for discussion with the panelists, and then from questions that have come in. So we have, and I'll just ask people to turn on their cameras. I'm not sure if I can see everybody. Yeah, it looks like everyone's on. So we have Randy Roberts and Jordan Lindsay and Thomas Egdorf joining us as our panelists. So Tish and I will be moderating, and Tish has the first question that we sort of organized to bring out some of the perspectives from the panel.
Awesome. Yes. Thanks, everybody. So yeah, the first question is, what supports are needed to help cope with grief and loss during the drug poisoning crisis? And what are community member experiences in regards to accessing support? Randy, this question is for you.
I always forget the mute button. My apologies. Hi, everyone. What supports are needed? Juno lists so many off that that is needed. And I have to thank him too, also on mentioning the people that don't get paid, right? I'm one of those people. I live in in Brantford, in a smaller city. And once you get past the GTA, all these services fade away, right? There's not all these harm reduction services and things we can reach out for. There's still people, organizations that are on the 12-step model, right? And trying to catch them up is part of the work we do as well, right? So it's hard getting services especially when we're not recognized for the work we do. You know, we have peers that are employed, but they are more kind of restricted on what they can say and do, where as unpaid ones, we do what we need to do, right? For example, I run a needle distribution and naloxone out of my home. Because I felt we're in the poorest part of town, but there's no harm reduction supplies. There's no place to get naloxone. So I feel that need, and I'm 24/7 a day. I also, because I live in housing, I have to address overdoses constantly, right? So there's that aspect. And yeah, we just need to be recognized and to also open up some of their services to us as well, right? Give us some of that professional service. I guess I could reach it, you know, go in and say, you know, I want help with, you know, my substance use, and then I can get it, right? But, you know, and I think a lot of the things we're doing for ourselves is as Jillian has mentioned, right? We have this guilt, right? I can't take no time off. It's always go, 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 right? Because if I do, then somebody's going to die, and it might be my best friend, right? So I can't take that time, you know, that chance, right? Even though we know we got to do it, right? And the guilt's just so much, and just seeing the amount of loss. Nobody wants to talk about it. When somebody has lost their friend, it's just brushed off, right? There's no funerals. There's no memorials. It's just move on to the next one. And I see why, because when I try to bring it up and I mention the person, you know, the tears start coming out, right? And then they just, you know, grab their supplies and leave, right? They're just uncomfortable with it right now. Because I'm sure, just like myself, I haven't lost my children's mother to overdose. You know, once you get into, you open that bottle, it's just going to keep coming, right? And so a lot of us, we're stuffing it down and hoping that, you know, this thing will pass soon, that we'll get safe supply. We'll get places to use where we won't be judged. Yeah, it's just, I'm really envious a lot of times of the services they have in Toronto, because we lack it here. Even for my Indigenous members, we live on a reserve that's the biggest in Canada, 6 Nations. However, they don't recognize harm reduction. So many of the unhoused here is Indigenous because they're shunned away from their community unless they go to these meetings, right? So they have a double whammy, right? They can't get it from their own culture. Settlers here, especially our government, is very conservative, and it's taken me 3 years, and we're still trying to get a safe consumption site here. Council refuses to address it, right? So that would help too, you know. So if I wouldn't have to fight City Hall, then I can concentrate on other things, right? So we deal with so many complex issues. It's watching our friends and loved ones going through this. Then it's fighting with hospital, because nobody wants to go to the hospital, as somebody had mentioned, right? Because of the stigma. I know somebody who's had 10 overdoses, and I can't imagine what that does to a person's body and mind, but won't go to the hospital, right? And the community I'm with, we've become so efficient at bringing people back that 911 is not even a thought for many people, right? You know, when I'm there, I try to encourage it, but I have to respect it as well, right? Their wishes. You know, there is that line that if it's too far, then I will, right? And they understand that. So yeah, just organizations, local, you know, expand throughout the province, right? And that's a thing we started with ONPUD. I'm also a member there. And it's recognizing that the services here in Brantford are bad. I can't imagine what they're like in Thunder Bay, or many of the reserves out there. It's got to be non-existent, right? I'm not even sure they have access to naloxone, right? So yeah, there's a whole lot that needs to be done. So we need help. And I'd like to applaud Juno for the work they're doing on all those, that initiative. I'm envious.
Thanks so much, Randy, and also recognizing you and all of your work, your words today, and you know, that local impact that you have, and also your work to connect across the province with others in your work in the community. I did see a hand up from Kim Baker, and we are into more the conversational part. So that would be great to hear from you if you're able to unmute your line, Kim.
Sure. Hi, everyone. Thank you for the presentation. I'm from Brantford, the same community that Randy is situated in. And one of the things that really sprung to mind as Juno was talking about the amazing array of services and supports at Breakaway. One of the things that sort of tweaked for me, and I actually wrote it down to talk to Randy about after, and I won't be the only one who probably had this thought, is, you know, within the context of Toronto and the GTA, there's, you know, you sort of talked about Breakaway as a bit arm's length. You were well-pillared community, and everybody's up in everybody's business generally. You know, for me, I think of the implementation challenge of having people feel comfortable, you know, who would host this in our community, and how would we frame it in a way that would enable people to access that service and not feel like the person that they're sitting next to at the next committee meeting is their helping provider as well. I think that will be a unique challenge for our small community as well as other small communities. So I'm wondering if there's any thoughts about that.
Thanks, Kim. I wondered if any of the panelists want to respond to Kim.
Maybe say one thing is that I think that one of the issues that Kim, that's underlying the point that Kim was just making, is the fact that we often don't know a lot about the needs that exist within smaller communities, within more rural communities, within places that are more remote. And I think that as we move forward and try to think about how to provide supports on a larger scale, there's also danger in taking a model that works well within the GTA, which, as you point out, is well resourced. There's a multitude of different settings where people can access services, and transplanting those models to smaller settings. So I think that there is a really strong need to actually ask within communities themselves what would work, and do kind of like the legwork on the ground and figuring out with communities. And that feels hard right now as well, because there's just so much need. And so there's kind of like this need to kind of like be expanding supports at the same time as making sure that we do get it right. And that it's not just this kind of like Toronto-centric model that just gets transplanted, or that we then like roll out in other parts of the province, where it may be more or less valid, and may actually also be harmful because of some of, I mean, drug use cultures are often very localized as well. This is where I think that we really, really need to hold true to keeping people who use drugs central in the development of the interventions and the policies around anything to do with drug use, is because, you know, like public health folks in Toronto are not going to know much about what people who use drugs in Brantford or other smaller centers are going to need. And in fact, could be actively harmful if we just start plopping things down in those kind of situations.
Yeah, I would definitely say it's in principle and conceptually scalable, 100%. And there would have to be some, you know, operational customization to fit the context of different communities across the province. So I'm looking forward to having more discussion locally about that.
Thanks so much, Kim and Gillian. So maybe we'll take one more question. Kevin and Tina, I see your hands up. Actually, two more questions. And then we have another prepared question to hear from Jordan as a panelist. So go ahead, Kevin.
Hi, I guess it wasn't so much a question, it's just about the needs, because I'm from Thunder Bay, Ontario. I work with Norwest Outreach Team, and some of the projects that we're on, like to help better for harm reduction, overdose response, like for Ontario, we've essentially just launched the Lifeguard Digital Health app, which is I find key for people who are using alone or using in houses, don't necessarily are not street orientated on the street, but you know, they might have jobs or such like that. And to kind of, we do have a wide variety of naloxone up here. Naloxone stats are up the through the roof. We are now launching our ComCap project through EMS. Hopefully the soft launch will be next week, which will essentially attach EMS referrals to peers such as myself, and we'll be able to go reach out to that person after they've been in an OD situation, and offer them services, whether it be consumption site or RAM or opioid substitute therapy or detox or stuff like that. But where I think if we're going to talk about what we're lacking up here is the space between detox and a facility for them to go. Like there's a lag in time. Like once a person gets out of detox, we'll say there isn't we don't really have too many places where to go, and then the relapse cycle ends up all over again. They'll relapse, and then OD cycle continues because again, like it just can't find the bed space. Just to give you a little bit of a key what's going on up here in Thunder Bay, and we just were in a meeting with Jordan from Trent Cadman about the Lifeguard Health app. So hopefully this will get pushed out to the rest of Ontario real soon.
Thanks so much, Kevin. It's great to hear about your work and also the connections between groups too, and yeah, great insights from what you're doing. And Tina, we'll take your question, and then we have another one for Jordan.
Hello, I'm not sure that it's so much a question as and maybe it is. I worked in addictions and mental health for almost 20 years. And one of the frustrations I experience as a registered nurse is often when programs come out, they start in Toronto, and I'm up in Midland. So we don't have access to those services. And, or when it finally gets here, it's so watered down that it doesn't have that same benefit. So one of the things I am wondering about this Toronto program is, as other communities start to look at what's available, will they be using virtual? Because we have now, we've used virtual telepsychiatry. There's so many things that we have up here where folks that I work with who would never, ever be able to get or afford the counseling they can get have been able to do it virtually. So is there a plan as to incorporate that as well? Because again, on my end, I'm now working as a telemedicine coordinator, and I've worked in harm reduction forever and a day. So often people will say, well, you know, they don't have a phone. Well, we have a room we can bring them to. I can do an exchange in that room. I can provide virtual care in that room, so on and so forth. So is that sort of on the table as well when programs are being put together? Thank you.
Yeah, that's a great question, Tina. And I wondered, Juno, do you have a response?
I do, yeah. Excuse me. Thank you, Tina. It actually happens that a lot, I would say probably half of the support we're delivering right now to people in Toronto is happening virtually. The only practitioners who work continuously in person are the ones who do the body-based wellness. So somatics, acupuncture, massage, shiatsu, etc. For as far as I know, everyone else is still working virtually. A, because we launched these while we were in lockdown. B, because I think it allows for more scheduling flexibility. But C, because some of these practitioners actually aren't even located in Toronto, such as Yvette Perot, who folks will know of. Yvette no longer lives in the city, but she is one of the core grief counseling providers through this program. So I think that has always been part of the model, just, you know, given the nature of launching a program during COVID. And I am hopeful that, I mean, the only restriction on us not being able to expand beyond Toronto is just our funding mandate right now. So the hope is that as funding grows, this will not just be localized to Toronto. Yeah, and it's, I mean, virtual is already working quite well where it's doable.
Thank you.
Great. Thanks so much, Juno, and for your question, Tina. So I have a question for Jordan, and then also we wanted to hear Thomas's perspectives, and Tish will ask that question. So first, for Jordan, what strategies have you used to support workers, and how are you reaching different groups? So workers who identify as Indigenous, workers who are not formally employed or compensated, how are you able to support the workers that you're intersecting with?
Thanks so much, Pam and Tish, and thanks to Jillian and Juno and Treaty for pulling all of this together, and for everyone for showing up for this courageous conversation. It's so important. And through our work with the COMCAP initiative, we have definitely found that this has been a gap for many of our communities. And for us, support strategies have really been about learning through the process and learning from and with people with lived and living expertise through action and reflection. So the lens that I would bring to this question is one of a support team member and a nurse and a settler living on traditional territories here, the Three Fires Confederacy, Odawa, Potawatomi, and Ojibwe nations. And as a nurse working in public health, I bear witness to the social injustices and the suffering on a day-to-day basis, and I'm in a very privileged position to be able to provide support. And the more and more that I do this work, we initiated our COMCAP project called the Peer-to-Peer Project about a year ago to engage with folks with lived and living expertise in our community around developing community response solutions for substance use, opioid poisonings, and homelessness. And I have absolutely learned more in the past year from working directly with experiential workers And as everyone said, both those informal roles and informal roles, paid and unpaid. And the folks that we have engaged in the COMCAP project refer to their roles as peer pathfinders. So working closely with them, and it has just absolutely shifted the way that I see the world and how I practice. And so I acknowledge that this perspective comes from them today. And this is really a reflection of strategies and approaches that have worked for us. And I totally acknowledge what everyone has said so far, that different things are going to work for different people at different times in different contexts. And there's even diversity within individuals, right? That what works for a person one day might not make sense in a different context. So support really has to be a practice of openness and acceptance and continuous learning and reflexivity to be adaptable to the diverse and changing needs of individuals and communities experiencing trauma and grief in all its forms. So a resounding theme in the work that we've done with folks with lived and living expertise is without a doubt that the most effective, safe, and accessible strategies to support individuals involved in overdose response are those that are provided in community by community. So by and for people with lived and living expertise. So our work is really focused on creating the conditions, building capacity and empowering folks in the community, and really reinstating the ownership and the agency for this work to come from the ground up. And working with folks to be able to provide care in ways and in settings, how and where they already are. So the right people, the right settings at the right times where folks feel like they belong, where they have trust and feel comfortable, and where they don't have to go to great lengths to attend a meeting or a service, where the person providing the service knows them and sees them for who they are and as an equal. So for us, the virtual modalities, what we have found with our folks experiencing homelessness, it doesn't work for us. It's really about showing up and from care provided in person from within the community. Because even when you try and facilitate those types of services, the screen just automatically becomes a barrier. And to bring someone to a space where we might be able to make that work, traditional service settings are just not spaces where our folks are able to access, and they don't feel safe. So, and especially for our groups, right, where they've been impacted by historical and ongoing medical and structural violence, such as our Indigenous communities and folks marginalized by homelessness and criminalization of substance use. So in understanding support really has to come from within the community. We view it as a process that requires a multifaceted and a layered approach. So there's no endpoint or destination in this work in the context that we're in right now. It's really about walking alongside the communities that we work with, and that this is a long-term commitment. And as a layered approach, support requires support. So in order for our folks in community that are caregivers, people with lived and living expertise, to help meet the needs of the community members that they work with, they require support to be able to do that. And for us, that has taken shape in our peer-to-peer program as what we call our Circle of Support team. And these are non-peer community members tied with different community organizations and agencies with access to supports and programs and services. And we wrap around the peer pathfinders and folks with lived and living expertise and build relationships and trust with them and help them to make connections to those resources with the power and privilege that we have in ways that it makes sense for the individual. So to give you some tangible examples of what that might look like, it's about frequent check-ins, debriefing, different forms of therapies, art and music, cooking, spiritual practice, sometimes just going to a quiet place, kind of away from the work and life settings, because they are so inextricably intertwined. So folks can have a break and decompress, and doing things that are completely unrelated to work as well is so important, so that people can experience some joy and look forward to something. And really just building relationships through that as well, because relationships are medicine. And in order for our circle of support team to be able to do that, we also require support. And what we find works best within the support team is support with each other. So with our peers, that's how we find support is best as well. Because we're sharing these experiences together. The work is really, really hard. And although we grapple with trauma and loss as well, working in this area, and albeit in more privileged ways, those experiences are valid. And in order for us to show up fully to be able to support the peer pathfinders in their communities, we have to take care of each other as well. And that doesn't negate the need for organizational support from where we're coming from. And then in order for organizations to be able to provide that support, they require support at a systems level as well, so that they can make those changes and provide more informed and accessible services. And that's really where Public Health Ontario has been able to provide that centralized support, so that folks on the ground, us at a community level, we're really able to focus on the action. So that's been really great. And support's also reciprocal. So working with folks with lived and living expertise, they're able to find the needs and the gaps in the community, and they inform us as the service providers about what we need to do to change our practices and our programs and services. And then we as the service providers advocate for changes within our organizations and so forth. So it's kind of like a chain or a pathway or a circle, really, that it's all interconnected, and it all works together to utilize knowledge and strategies that really comes from peers and people who use drugs, and what they've done to take care of each other for decades. So we really just wrap around the folks in community that are already positioned in these care roles to make sure that we lift the community up in ways that are flexible and open, peer-led, strengths-based, grounded in cultural safety and trauma and violence informed care, and are dignity and compassion centered.
Thanks so much, Jordan. It's been great hearing along the way about your experience in kind of developing this practice around the circle of care and multiple layers of support being in place with your team and organization around people who are doing the direct service work. So Tish, over to you, and you have a question prepared for Thomas to hear the perspective you bring today.
Yes, thank you. Thomas, how can organizations enhance the supports that are available to staff and community around grief and loss? Example, what ABRPO training resources structures exist to support organizations in supporting their workers?
Thanks for that question, and thanks to the organizers for having me. I think the organizers are going to put either in the chat or send in an email afterwards a couple of key links to some of our capacity building work. But I think I want to start maybe controversially by saying it really frustrates me that in this day and age, EAP programs are still unable to respond effectively to staff who work in harm reduction. I really encourage everyone on this call to speak to the leadership of their organizations and talk about how to hold those EAP providers accountable. We spend a lot of money on this service, and what other services there out there if we kept getting incompetent and inadequate service that we would continue to use. So, you know, I think EAP has its place, but it needs to be people who are competent in dealing with the people we work with. ABRPO over the last year and a half really have been focused on moving our key content online during COVID and even pre-COVID, recognizing that we can't be everywhere at once. And, you know, recognizing that agencies sometimes are not able to respond effectively to the ongoing grief loss and resiliency needs of staff. For myself, I've been working in the field of HIV and lately in harm reduction for 28 years. And during that time, I've had some managers and organizations that really get it and provide supports for their staff. And I've also worked in agencies that didn't, or managers that didn't. So for me, I'm really big on developing my own skills and ability to support me and my peers and colleagues. Because peer-to-peer support has been shown time and time again to be by far the very best support. And in agencies I've worked at the end of the shift or during a crisis point in the shift that I'm working in, being able to say to someone, can I debrief with you or can I touch base with you in the moment, and having someone that's able to do that. And for me to be able to do that as well is so important. I employ a number of things in my day-to-day life to help me stay grounded and stay well in this work. And that's how I've been able to be in this work for almost 3 decades. And they don't all have to cost money. So one of the things I use a lot are grounding stones. And the one I have in my hand right now is one that I found on the side of the road. So it didn't cost me anything to do, and I have that in my pocket whenever I leave the home, and oftentimes when I'm on these calls I have it in my hand, and just as a way to keep me present and keep me grounded, because it can be really scary talking to 80 or 90 or however many people are on this call, and this just helps me with that. I really encourage you to visit our website. The website's been completely revamped and launched this summer. We're constantly having new courses and modules come up. There's one on right now, holistic check-ins, which is a model of checking in all quadrants of a being. We have a really great short course on grounding to help give people ideas of grounding, using your feet, for example, using the stones, as I mentioned, simple breath work. I know for some people that can be really triggering who have a trauma history. So there's many others. Being in nature, if you're able to be in nature, I try to go for walks throughout the day, especially on a stressful day, to find even 10 minutes to walk around the block can really help. Visualizations and focusing on the senses is just some of the different ways. But I would really, you know, I can't possibly talk about all of that in the few minutes I have. So please click on the links in the chat or visit our website at abrpo.org. Thanks.
Thanks so much, Thomas. And I think we're going to actually use one of your clips for a moment of care that Tish will lead us in. We'll just slide it in our last couple of minutes before we get cut off. Thanks.
Yes. Awesome. Well, thank you everybody for attending in your space and time and sharing your resources. I think it's really important. And just noting that the privilege that we have with our 4 walls to be able to access internet and have these resources at our disposal. So yeah, like Pamela said, we're gonna try and do, or I would invite you to do a grounding exercise, and just to bring us back to present so we can continue on with our work. And I appreciate everybody today.
Practicing grounding with the feet. Get comfortable where you're sitting or standing. Place your feet flat against the floor or against the surface beneath you. You might wiggle your toes or press your feet into the floor if that feels good. Take a moment to feel the support of the floor. Notice its qualities. What is its texture? Is it hard or soft? Can you feel its temperature? Now imagine that there are roots growing out of the bottom of each foot, extending down through the floor into the earth. Your roots give you strength and nourishment from the earth, just like a plant or a tree. Be with this feeling of nourishment for a few moments.
I think that was the end of the clip. We're just coming down to our very last minute. So thanks so much everyone for being involved and everyone who was here to participate. I'd encourage you to fill out the evaluation, watch for more of the resources to come out from everyone and the resource list that we've put together. The evaluation link is in the chat. So thanks so much to everyone and have a great weekend and rest of the day.